I just want to point out that in the presentation it talked about electronic health records, and I'm hoping in the next 10 minutes that I'm going to share with you that a simple concept of an electronic health record is not simple at all. And as noted in my heading, I like to think of this as e-health and the introduction of e-health into New Zealand, in the same way that over the last 20 years we've seen e-business come into the commercial world, and now we don't talk about e-business, we just talk about business that is enabled by digital and IT. And I'm very mindful that in 10 years' time we won't talk about e-health either. We'll just talk about a new generation of how we operationalise and how we support better health care for all New Zealanders, and it'll be much more digital. So I'm leading a bit of a campaign, you might think, of moving us from fundamentally a paper-based and telephone-based health system to a health system that optimises the digital experience, which is why the heading just underneath, where I'm wanting to give you a progress update on what we're doing, but very much from a privacy as a design constraint, as a design benefit. And I just want to focus on the word design for a moment. Design means you're having to make some compromises. The best designers in the world are having to manage the difference between form and function. So today is all about what are those compromises and how do we do it in an open way so we bring our community and our professionals with us. I think the other thing, just before I start, is the difference that has happened in the last 3 or 4 years with the way we think about e-health is that everything we do is focused on the patient and the consumer and their experience in the health system. And it's a very high ground statement, but if you start with the consumer, a quality outcome and their trust, then actually privacy falls into place relatively easily. I won't say easily, but I'll say it's easier. So I'm going to get you all to think about your own experience of the health system, the world you're currently in, of basically a paper-based world, and what the new digital world is going to be like and what it will mean for New Zealanders. So the first thing is that it's not easy, and in fact, for anyone who's been involved in IT systems and digital systems, you need to have a very clear concept of the industry you are in. And the comment I would make about the health sector, as noted at the bottom there, is health is still a very young science. The science of health is growing and changing all the time. The idea that now you can have personalised health interventions that are related to your genome, that are related to your the way proteins are processed within your personal environment of your own body, is still being discovered every day. And a very simple example that I use is that we used to have a concept of cancer of the kidneys, and yet today people thought it was one type of cancer. They now realise it's 14 different types of cancer, and I'm assuming in the next 10 years they'll find it's 100 types of cancer just for that one organ. So the idea that I implement a beautiful electronic health record that talks about one type of cancer for the kidney, and then I find that actually I've got 14 or 100, I've got to be very adaptable. So I use this example here of the almost successful yacht that we developed. But the point about it is that it's a platform. It was designed as a platform to innovate on. And we innovated very, very fast, just not quite fast enough to win that last race. But health IT needs to be thought about in the same way, and we won't meet the needs of our consumers if we don't have an adaptive e-health environment. So how might we describe that to New Zealanders? So a New Zealander is thinking about maybe logging on and looking at their health information when they're sitting in the comfort of their own home. However, it could get very complex. So just imagine from the moment that a baby is born, or even that someone is found to be pregnant, through to the time when they come to the end of their lives. Just imagine the digital information that could be captured about that life stage and all the events that occurred in that. So the way we think about that is we use this idea of a tree. So the health information that is captured over someone's life is like a beautiful old pahutakawa tree, which is on an island just in the Hauraki Gulf, that has been there for over 100 years. And depending on someone's health experience and the number of connections and touch points with the healthcare environment, that tree will bloom in a range of different branches. If someone does have a long-term health condition, they may have a whole branch of health information that the rest of us won't have. If someone has a very bad accident, they'll have a whole group of information around their recovery, the treatment and the care that's required, or mental health. And so by the end of our lives, we'll have a range of different trees. Someone who's been fit and healthy might have something looking like a pine tree. There's a gentleman called Ernie Newman who created our consumer group. He's a little bit smaller and rounder, and he thought his tree would look like a gorse bush. He said it himself, so I'm just repeating his own information. So what the ministry had to think about is what role should it play, and what role should it ask the rest of the health system to play, which is made up of hundreds of different organisations that are public and private. And we decided we needed to get the core right of the tree, the roots of the tree. So we needed to make sure identity of the individual, the identity of the providers and practitioners and health workers who are going to support that individual. We want to make sure things like allergies and alerts are captured once and made available, because they may cause or be very valuable at the time of an emergency. But that's where we felt we needed to stop. We did think we needed the ministry to play a role in setting the branches of the tree and the arrow going up through the trunk of the tree and the overall environment. So you might see on the slide down the bottom right this concept of connected health. So what we've provided over a number of years, but we've branded much more strongly, is the idea that there is a private network just for health information, and health providers and consumers can be confident and trust the fact that their information is within that private network. Now, I'll go through the next couple of layers very quickly. I just wanted to give you the idea of the model that we're working to, and this underpins all of the projects we work on. So we're asking that across the health system, your clinical information, the information no one can argue with, so these are test results, the medicines you've been prescribed with, they need to be understood throughout the health system. There is no debate about that, and when we talk to our consumer groups, they tell us we're not worried about that so much. We're much more concerned about some of the things that people write about us, because that's a bit more personal. So there's a level of information here that is objective and we can share readily within the professional models that we already have in health. The next layer is we call continuum of care, where this is what the majority of us would experience if we go through a primary healthcare experience with our GP. We might end up in a hospital for a short period of time, back into the community. So it's the episodic care. And then we have a model for the people who are at the top of the tree, who have got a much more complex relationship with the health system, with multiple providers, and maybe over a long period of time with a long-term condition. But also on the left-hand side, there's a concept of wellness. So this could be things like people who are pregnant, mothers-to-be, actually well, but they also will have a long and relatively complex relationship with different parts of the health system. So I just wanted to pick up on 3 projects that we've made a lot of progress on. 20 years ago, we put a National Health Index number in place. We've now replaced that with a very modern master data management system run by the ministry, but operated across 35 organisations that make up the health system. And more are coming on all the time. We're promoting the fact that general practice and general practitioners should be offering New Zealanders access to a patient portal experience that is part of a service delivery they're already offering. So it's not coming from the Ministry of Health. Just imagine that for a moment. So you're sitting at home and you log in and you see a piece of data that's wrong. I don't want you ringing me. What am I going to do? But there are countries around the world that are implementing electronic health records from the centre out to their communities, bypassing all the professionalism. I think that's crazy. So what I want you to do is go, there's some data in my portal that isn't what I expected. I'm going to ring the GP practice and ask them about it, because it's part of their service they're delivering me. And if it isn't theirs, then they'll be my best advocate to go and find out who should be adjusting that information or following that up. It's very important that our patient portal experience will be driven around a wellness scenario. However, we're not leaving the hospitals alone. We're doing a lot of work with the hospitals to ensure they have common systems around the way they manage medicines, clinical information, and the way that they interface between the two, because it's the transition in and out of hospital that sometimes causes a lot of issues around quality of care. And then we're in the throes of implementing a single shared care plan for complex cases. So that's the model we're implementing for New Zealand. It's going to be all done on a private network for health that is already in place, and we're developing these investments over time. But it's not the ministry spending all the money, it's all of the healthcare organisations, whether it's NGOs, Plunkett, all of them need to understand the ecosystem they're plugging into. Our job is to create the environment. So this is the sort of thing we're starting to see. The whole of the South Island, clinicians who work in the South Island log in the mornings to their local system and then can get a login through to this thing called Health Connect South. And that is that layer that I talked about of common clinical information. So in fact, if anyone's living in the South Island, good and well done, because you guys are going really well in terms of health and access to information. And I really do think that they're going to be the leaders over the next 3 or 4 years. So this is the sort of environment we want to have, highly secure, based around professionalism, and ensuring that consumers understand what is coming and how it is being used on their behalf. So look, I'll just finish by throwing up some e-health principles. And I talked about a balancing act. You know, this is about balancing the features, and that's why we need to use design. So a couple of just thoughts around this. Consumers own their information. The Privacy Act makes that very clear. I've got own in commas there because as public entities, they're not able to delete information, but the real point about this is consumers know it's their information and we are the custodians and stewards of that. The second thing is we've tried to get all the professionals in the health system to understand it's better that people know the information than not know the information. So the example is you turn up at ED. Wouldn't it be better that the clinician working with you knows the primary health information than the last time that you went to the GP? Now, clearly there may be reasons why you might want to withhold that, so there is the opt-out provision. But as a general principle, to know the information is better than not to know it. The next point is that consumers are very clear. Nothing about us without us. So we need to have them deeply involved in the design of these solutions so that they understand the experience that are going to be offered and how their information is going to be used. And then we do need the option for people to step out. And I need you to understand that in the experience around New Zealand, as these systems are being rolled out, there is a small percentage of New Zealanders who say, thank you, that's not for me. But it's very small. But they must have that opportunity to put that forward. And then from a pure privacy point of view, we need to be disciplined, and we need, before we go near completing the design and the development and the implementation of any of the e-health solutions we're making, we must do a privacy impact assessment to double check that we are covering off all of the potential issues. So I'm going to finish up there, but I just want you to understand that there's a concept out there called big data, and I don't know if people realise it, but it actually came out of an IBM research lab, and their marketers thought this was wonderful. Because big data means that we've got to buy more computers, and therefore there's a commercial reality. But the point I'd like us to focus on is not the data part of that conversation, but the big. Getting digital right is a really big problem. Do not assume it's simple. This is just a slide of the groups that we work with. And in particular, right at the top left, we're advised by a consumer group and a clinical leadership group working nationally with us. If we didn't have those groups debating with us, challenging us, and putting their own expectations in front of us, then we wouldn't be able to do the job we need to do on their behalf with all these other groups. Thank you.